So welcome to the National Fellow Online Lecture Series. This is a lecture series sponsored by our Fellows Online Education Subcommittee, which is part of the Education and Fellowship Committee of AMSSM. Tonight, we are excited to have Dr. Erek Latzka come to talk to us about non-traumatic hand and wrist injuries. Dr. Latzka is a sports medicine fellowship trained physiatrist at Boston Sports and Biologics. He completed medical school at Tufts University in Boston and did his physical medicine and rehabilitation residency at University of Washington in Seattle. He did an ACGME sports medicine fellowship at the Swedish Medical Center, where he developed his skills in diagnostic ultrasound, ultrasound guided procedures, and orthobiologics. He has received many recognitions and awards. Of note, one was the University of Washington Sports Medicine Department Teacher of the Year in 2022. Dr. Latzka's clinical interests in prior research have focused on the upper extremity with topics including diagnostic ultrasound of the shoulder, orthobiologics for adhesive capsulitis, ultrasound-guided carpal tunnel release, or ultrasound-guided trigger finger release, as well as rock climbing sports medicine. He currently serves as a member of the AAPMR Biologics Curriculum Committee and the AAPMR Technical Expert Panel on Biologic Management of Osteoarthritis of the Knee. We are excited to have Dr. Erek Latzka here, and will be available for questions after the talk as well. The goals of these lecture series is to be an adjunct to your home program's educational content. We're hoping to provide your fellows with direct access to educational experiences with the AMSSM members and sometimes invited guest experts. We hope to assist with your CAQ exam preparation. In order to do this to the best of our ability, we want to make sure we have input from you. We want ideas on topics, different ideas for speaker suggestions. We really try to reach broadly to get across all specialties and all parts of the country. So, if you haven't seen your area represented, please reach out, give us some ideas. You can either go to the amsssm.org website and find a form to put in information, or you can click on this QR code and it'll take you directly to that form. But remember, the primary goal of this lecture series is to assist you in your CAQ preparation. Hopefully we have done that, and we look forward to seeing you again next week.
Thanks for the introduction, Laura. I'll be talking about non-traumatic injuries of the hand and wrist. I have no disclosures. Laura just went over these things, so we can skip through that. And this is the reason why I moved back from Seattle to Boston. Luckily, I was able to join a great practice here with Dr. Sussman in Boston Sports and Biologics. And it was just a great fit. He's another sports medicine physiatrist like myself. And it's kind of important to define what that is, especially in, today when some professional leagues don't really consider us equal, and maybe some in this organization. We do 1-year internships in internal medicine or general surgery, followed by 3 years of PM&R. And those 3 years include 13 months of inpatient on adult and pediatric services. We have to manage patients with severe TBIs, spinal cord injuries, strokes, burns, polytrauma. So we get a lot of primary care, just in a different kind of setting. And then we do a sports medicine fellowship, the same one that everyone does, with the same CAQ, and we are accredited by the same board. There's a lot of great sports medicine physiatrists out there who've been head team physicians in the past, including one of my mentors, Stan Herring. My favorite of all, though, is Matt LaCourse at the bottom of the screen here. He's on the side of him. There are some images of a athlete who would not be alive today if it wasn't for Matt recognizing that he was having a stroke while on an international flight. He's part of the U.S. Deaf National Soccer Team, and Matt stopped the flight, had it make an emergency landing, and they were able to save him. So the topics we'll go over today have been covered before in some lectures. Here are some of the lectures already available on AMSSM's YouTube. I've been involved in at least 3 of these, either with my fellows at the time or just by myself. The sports injuries of the hand and wrist one a couple years ago. But that one we had to cover a lot of diagnoses in a short amount of time. And so switching to non-traumatic injuries allows me to get rid of about half of those diagnoses and focus on a few new ones like Dupuytren's. I'm also going to reorganize these into a different format. So we'll start with the bony injuries, move on to nerve injuries, then muscle and tendon, and finally ligament and fascia. Number one is CMC osteoarthritis. This is a very common, non-traumatic injury that is particularly found in your middle-aged, older adults. They'll present with pain with gripping, pinching, throwing, trying to open jars, handshakes, opening doors. It's usually radial, can be volar or dorsal. And on exam, the CMC grind, so the pushing the thumb, axially loading it, and then rotating should produce some pain. There's also an enlarged out of joint appearance at the base of the thumb. Your gold standard for this is going to be the X-ray. Should be able to see this is a severe case over here on the right, but it can also be seen on ultrasound. So here we have the trapezium, and then the metacarpal, and the CMC osteoarthritis in between. Now, how do we treat this? It depends on what you read and when you read it. For the CAQ, I'd recommend that your answer be spica splint number 1, corticosteroid injections number 2, and surgery number 3. Now, all of that being said, there have been some new studies, randomized control trials, and systematic reviews showing that PRP plus MFAP might be a better treatment than any of the others that we have. So that's a new study, but here it is if you want to take a look at it. And then if the patient's young, seemingly too young to develop this degenerative arthritis, consider inflammatory disorders. And that's going to be a take-home message from this whole talk. A lot of these, what should be degenerative or non-traumatic injuries, if you're seeing them in young people in an atraumatic setting, think about an inflammatory rheumatologic workup. So next we have distal radial epiphysitis or gymnast wrist. This is an injury that's caused by repetitive axial loading. Now, there's a typical kind of threshold for that. It's usually over 35 hours per week and during a growth spurt age, so usually between ages 12 and 14. The typical athletes experiencing this are gymnasts and weightlifters. It's a pretty nonspecific exam, though, just with tenderness of the radius, and range of motion can often be normal. So if you have an athlete in those age groups, doing those kind of hours, you want to have a low threshold to get x-rays and make sure they're bilateral to compare the growth plates. And then if the x-rays are normal, have a low threshold for an MRI. And the reason you want a low threshold is because if you miss this, this can lead to some deformity and some deformity down the road, and it definitely affect their function long term. So you need to cast and splint them to prevent hyperextension. If you don't, they'll end up with a positive ulnar variance and a Madelung type deformity with a shortened radius. Number 3, ganglion cysts. So these are often asymptomatic and chronic, and they can come and go. They can pop on their own. Usually they're dorsal, much more common than volarly. And they're, if they become painful, then they're worth treating. But if they're not painful and they're just there, try to talk patients out of doing anything, because they often recur even when aspirated or even when injected with corticosteroid. Surgical removal will be, the next step if they do recur. Another tip is don't go and try to drain them or inject them without ultrasound or without an imaging confirmation first, because I've seen plenty of ganglion cyst referrals that did not turn out to be ganglion cysts. They turned out to be inflammatory extensor tenosynovitis. They turned out to be nerve sheath tumors. So there's a host of things that can present, median nerve hamartomas. There's a lot of different things that you can get in the wrist that aren't ganglion cysts. So get that imaging confirmation first. On the right here, we have an MRI of the ganglion cyst coming from the scapholunate joint, which is the most common. Then here we have the ultrasound corollary. And finally, the injection. The key with the injection, I always recommend using a gel step-off, and then you can see your needle much earlier as you tract down towards the cyst. Fourth, we have Kienbach's disease. or AVN of the lunate. This is one that's easy to miss, and it usually is missed because of the minimal trauma experienced. So, if you can even call it trauma, I included this because it's not really trauma that's happening. It's just the repetitive nature of the sport. So the repetitive wrist twisting or extension or loading for linemen on the ground. So this happens in males, often 20 to 40 years old, increased risk in those with lupus or sickle cell. Again, the exam will be nonspecific. There will be tenderness or palpation of the wrist, some decreased range of motion. But early on, this can look like a very normal wrist. And even the x-rays may not show what we're seeing here, which is sclerosis of that lunate and flattening of the lunate. Down the road, in more chronic cases, we can even see fragmentation or collapse of the lunate. So if something just doesn't feel right, and this has been a chronic, recurrent symptom for this athlete, get an MRI, and that's going to be your gold standard to rule this out. Another thing you might notice is the variance of the ulna. So if you see a negative ulnar variance, that might be the one thing that pushes you to get an MRI in somebody presenting with these symptoms, because every other thing that we'll talk about today is probably associated with a positive ulnar variance, such as ulnar impaction syndrome or TFCC tears. So a negative ulnar variance, though, think about Kienbach's disease and get an MRI. Alternatively, as we just talked, speaking of ulnar variance, here's a positive ulnar variance where the ulna is longer or goes past the end of the radius. Typically, this abutment or impaction syndrome occurs in middle-aged patients, but it can be in younger patients who are participating in boxing or MMA. It will present like a TFCC, so tenderness at the ulnar fovea, positive TFCC maneuvers, grind, and I think I have it. The X-ray can show positive ulnar variance. MRIs can show some signal in the bone, like we see here in the earlier cases. And then in the later, more chronic cases, you can see actual sclerosis and subchondral cysts in these same locations. The downside of this is it usually requires surgical treatment with resection of the ulnar head. If not, this will just continue to lead to further degeneration and further tearing of the TFCC. Bowler's thumb, you can think of it like Morton's neuroma almost of the thumb. It's due to chronic recurrent compression at the thumb hole of a bowling ball and presents with paresthesias and pain in the thumb. The exam can show a positive Tinel's if you're tapping on that medial border of the thumb. There's numbness in the web space, and you might even feel a palpable mass, as you can see on these images here of the ultrasound image here and the surgical image here. These neuromas can get pretty thick, and the treatment, again, kind of like Morton's neuroma, first thing, rest. Second thing, try to offload the area. So how do we offload this? By guarding the thumb with a thumb guard if you're going to continue to bowl, changing the grip. And then finally, ultrasound-guided corticosteroid injections are the next step. Most people aren't having surgery for this, though. Carpal tunnel syndrome. So this is something that is not occurring in your software engineers. This is more in your blue-collar workers. And if it's happening in athletes, it's the ones with repetitive wrist flexion and extension. So thinking gymnasts, weightlifters, cyclists, rowers, wheelchair athletes. And as this should occur in the first through the 3.5 digits, the radial half of that fourth digit. The flick sign is just a history, something you should gather on history. A patient says, oh, I do this to, I wake up, my fingers are tingling, and I do this, and the pain gets better. That's a pretty specific and sensitive sign. So pay attention to that. It's likely that it's coming from their hand and not their neck. The exam, though, should still show some specific tests like Phelan's, carpal compression, Tinel's at the wrist. The diagnosis, gold standard, is EMG, showing slow conduction across the wrist compared to the ulnar nerve and radial nerve. Ultrasound, though, can be used, and we can see the median nerve here in its honeycombed appearance. This is a normal looking median nerve. But with carpal tunnel syndrome, we'll see it loses that honeycombed appearance. It becomes much more, much darker and much larger. So this is has a cross-sectional area of 0.24 centimeters, which is more than twice of what it should be. 0.09 is your upper limit of normal. The other thing you can see is a notch sign. So then in long axis, you can see a normal median nerve here, and the diameter of the diameter that we're measuring here is decreased by 50% once it gets underneath the transverse carpal ligament. So that's another sign of compression of the median nerve. Now, treatment for the CAQ, first thing you should say, avoiding activity modifications, using a wrist brace during exacerbating activities, especially sleeping. Next thing, corticosteroid for temporary relief, and then if recalcitrant, a release. Now, if there's motor involvement or it's severe on the EMG, you could make the argument to jump over the conservative therapies straight to surgery. The last thing I have down here about ultrasound guided releases, probably not something you want to answer on your CAQ. I'm sure I don't know if they're up to date on the data for ultrasound guided releases, which do show equal long-term outcomes compared to open carpal tunnel release, but a faster recovery in the short term. So this is one of those ultrasound guided techniques, the Sonex technique, and it's probably the most well studied and most commonly performed option in the US, at least. This is a great randomized control study written by Kyle Eberlin at MGH, showing equal outcomes in the long term, but some better outcomes in the short term. What was interesting is that the surgeons who did the study, all 12 surgeons, they had a lot of experience with the mini open carpal tunnel release, having performed over 1,000 of them. But on average, they'd only done 12 ultrasound guided carpal tunnel releases. So once they started doing it, they got really good outcomes early on. This is how you visualize that procedure under ultrasound. So the key here is being good with your diagnostic ultrasound and being able to see the things that you want to cut and don't want to cut, being able to differentiate the median nerve from the TCL. There's another technique called the GO technique. And let me make sure I have the volume off for these videos. Good, but it involves inserting a needle underneath the TCL and then putting a thread through that needle, removing the needle, using the same entry and exit points going now above the TCL, looping the thread back around that ligament, applying some handles to the TCL, to the thread to allow a grip, and then pulling back and forth in a slow motion so that thread can cut through the TCL. Now, this is just another ultrasound guided technique with a lot of really good evidence and really great outcomes. This is how we see it under ultrasound. We have the long axis view of the thread on top and the short axis view of the thread on bottom. Again, the key here is anything that's in between those threads is going to be cut when you start pulling. So you want to make sure that every important thing, like the superficial ulnar arch here or the recurrent median motor branch, those are not between your threads. These are some studies recently on the GO technique, or not, some of them recent, some of them not. First published in 2015 when the GOs developed the technique. Then a retrospective safety review showed it to be a very safe and effective procedure with office workers returning on post-op day 1. Mayo Clinic study in 2022 showed a 3 times faster return to work than compared to a surgical group. In 2024, they took a cohort of severe carpal tunnel patients, did 82 thread releases, and showed no recurrence 2 years later. And most recently, just published, another Mayo Clinic study, this one pretty unique in that they did an intra-subject controlled study. So basically patients who had bilateral carpal tunnel syndrome were randomized to get the thread on one side and the mini open release on the other side. And all but one patient preferred the thread at all time points from 1 week to 52 weeks. Not many places you can get this done currently, but there are more, every 6 months since I started doing it. These 4 locations are people that I've connected with the Gow brothers, or people that I help to train in their residency and fellowships for both. Next, cyclist palsy or ulnar neuropathy at the wrist. This is common in cyclists, obviously, but also in weightlifters performing bench press or wheelchair athletes. The numbness of the 4th and 5th digits should be your key. ADM weakness, FDI weakness, and ulnar claw if there's motor involvement. Gold standard diagnosis is your EMG and nerve conduction study. But you can, there's more clinical data that can key you in on, which branch of the ulnar nerve or at what level is the ulnar nerve being compressed. So not all cyclist palsy is the same. Some will present with weakness of all their intrinsic hand muscles except the hypothenar. Some may just have sensory loss in the 4th and 5th digits, but intact strength. And so you need to think about the different branches. Now, if this happens at site A, the main trunk here, you're going to get all of those symptoms. If it happens at site C, at the deep branch, you're going to get just weakness, but some sensory changes. So it's not all cyclist palsy is the same. Treatment, though, should be, number one, a bike fit to make sure patients or cyclists aren't putting too much pressure on their hands. Gloves, changing the handlebar grip. And if there is motor loss, though, if this is a severe neuropathy with axonal loss, then surgical decompression may be warranted, especially in cases where it's complicated by other things that are putting pressure on the nerve, such as ganglion cysts. Here's an example of that, where a ganglion cyst, this is a racket sport athlete, probably had repetitive trauma to the hamate, developed this ganglion cyst that was compressing the superficial branch of the ulnar nerve. Wartenberg syndrome is a neuropathy of the superficial radial nerve. Now, this is most often due to just wearing tight wristbands, or watches, or weightlifting bands. So weightlifters, especially Olympic weightlifters, will wear tight straps around the wrist to help them if they don't have adequate grip strength, if they're trying to lift something more than they can grip. Now, Tinel's test will show positive, tingling if you tap at the Wartensburg point between the brachioradialis and the ERCL. Now, Finkelstein test could also be positive due to traction on the nerve, but that's going to be, that might distract you, and you might just start thinking that it's de Quervain's, but it's not. De Quervain's should not have numbness and tingling in that distribution, or numbness and tingling at all. So the treatment is removal of compression, and after that, spontaneous resolution is common. These rarely require any injections or surgery. Speaking of de Quervain's tenosynovitis, it is a tenosynovitis of the first dorsal compartment, so the APL and the EPB. It's due to repetitive grip and ulnar deviation, most commonly in new moms. So especially when they're going to take their baby, put them down in the crib, and they're doing that eccentric motion with their wrist that's stretching the first dorsal compartment. But it can also be seen in golfers, fishermen, racket sports. The exam test that will be on the CAQ is Finkelstein's test, but Eichhoff's test is actually a more appropriate name for it. And there is a slight difference in those two tests, but they're essentially both testing for the same thing. Now, confirming your diagnosis, imaging, ultrasound, or MRI can make that diagnosis for you. It'll show a thickened extensor retinaculum and tenosynovitis. So what that looks like is here, a thickened retinaculum with tenosynovitis around it. Let's go back though. And look down here where we're talking about first dorsal compartment can travel in separate sheaths. So this might come up on the test too, because what you want, if you're doing an injection, you want to make sure that you're in the right sheath. If the APL is affected but not the EPB, you might miss it if you're not using ultrasound guidance. So this is one I would definitely recommend ultrasound guidance for, to make sure you're in the right sheath and to make sure you're not getting the superficial radial nerve on accident. Here are some of those variations in how the APL and EPB can travel, either within the same sheath here, separate sheaths here, or the EPB completely not involved. And then this is what it looks like under ultrasound. To do the injection, I like to come in long axis from distal to proximal with the gel step off again, so I can see my needle earlier. And ideally, you're not just putting the steroid in between the retinaculum and the tendon sheath, but I would recommend peppering this whole thickened retinaculum with steroid. Under ultrasound guidance, the corticosteroid injection can be curative in as high as 97% of cases, 82% with blind injections. The risk of hypopigmentation, though, is high and should be patients should be counseled about that risk. You can see it here, this area of almost some fat atrophy and hypopigmentation. Now, that should improve in a year as the melanocytes repopulate and fat is redistributed. And again, note this is the most common tenosynovitis in wrist tenosynovitis in athletes. For chronic cases that continue, the surgical release can be done, but there are some ultrasound guided releases that have been reported over the past 5 to 7 years, showing good outcomes. And the only thing is, not too many people are doing these yet. We published a review, and I think these are the only studies we found in the literature, a series of 35 cases and then 10 cases, but there was a 91 to 100% success rate without complications and no recurrence. Next diagnosis is proximal intersection syndrome. So this involves the first and the second dorsal compartment here. It presents as radial wrist pain in repetitive wrist extension. So your crew athletes, weightlifters, and racket sports, there's tenderness to palpation proximal to Lister's tubercle. And the most unique thing on the exam is this kind of palpable and sometimes audible crepitus, this kind of squeaking sound you can get and feel in that area. On imaging, and here's an ultrasound of a normal, this is a normal intersection. You can see how the second compartment passes over the first here, or the first over the second, sorry. The treatment is rest, neutral wrist splint, sometimes NSAIDs, sometimes a corticosteroid injection. Here's an example of the corticosteroid injection in between the two compartments. Now, if you use color Doppler, you can see tenosynovitis of both. If you get an MRI, you can see a corresponding tenosynovitis of the two compartments here. Distal intersection syndrome is of the second and third dorsal compartment. So now the EPL is involved, passing over the second compartment. And the typical athlete or patient who has this is usually a drummer. And the pain is distal to Lister's tubercle, so that'll be your differentiation. Crepitus isn't as common, but you can still have it. Pain and weakness with thumb extension is definitely going to be on your exam. And your diagnostics, similar to the last one, you want to follow your EPL as it passes over the second dorsal compartment, looking for tenosynovitis in that area. The treatment will be rest and a spica splint. Here we see the second dorsal compartment and the third, both with tenosynovitis on an MRI. And just know that if conservative measures don't work, there is a low threshold for operative release of the second dorsal compartment. That's not an unreasonable option for a drummer who's having recurrent symptoms. And what would be worse for the drummer is to have a rupture of the EPL. And I think that's what we're trying to avoid. So then extensor tenosynovitis. This is a more unique one because it's very common in rheumatologic disorders. So rheumatoid arthritis, spondyloarthropathies, and I've seen that in multiple young people who did not know they had a rheumatologic disorder. They're in their 20s, and this was one of the first things they presented with, this mass at the back of the wrist, swelling, pain. But on ultrasound, you'll see a lot of tenosynovitis, more so than you would expect, especially without trauma. So this is an insidious onset of swelling and pain, visible on ultrasound or MRI. There is also usually a thickened extensor retinaculum, and your goal should be to drain some of this fluid, send it for analysis, but also start an inflammatory workup with the appropriate labs, ESR, CRP, rheumatoid factor, NA, anti-CCP, HLA-B27. And I usually would start a room consult early, since they usually take a long time to get. Now, 14, ECU tendinopathy or subluxation. So this is common in, again, racket sports, club sports, high impact sports. This is a image of the ECU synergy test reproducing pain in that area. With supination and pronation, it should sublux with the former and reduce with the latter. On imaging, we can see a thickened retinaculum around the ulna here with some cortical irregularity. And that same thing can be seen on MRI. Here we have an MRI showing that the ECU is at sublux out of this groove. Treatment for this, rest, splinting, and if it's recurrent and chronic, then an ECU sheath reconstruction. So sometimes, especially if it's subluxing, they may need to recreate this retinaculum. And again, if it's not an athlete and this is a young person, think about rheumatoid arthritis. Next is trigger finger. So trigger finger is due to a thickening of the A1 pulley here. This is most commonly a degenerative issue, just in older middle-aged adults, but can also be found in younger racket sports and rock climbing athletes. Now, on exam, tenderness palpation at the area of the A1 pulley. Where is that on the hand? That is right in front of the knuckle. So if you go to the knuckle, go to the other side, that's where your A1 pulley is going to be. That's where they'll be tender. You may feel and see dynamic triggering of the finger, but not always. I have a lot of patients who come in and say, I have triggering in the morning when I wake up. It triggers for about 4 or 5 times. It's extremely painful. And then the rest of the day, I'm okay. So if they have that kind of history, you might only see tenderness on exam. You might only see a thickened A1 pulley on ultrasound. Here's what that thickened pulley looks like. Here it's 0.14 centimeters. It shouldn't be more than 0.04 centimeters. Here's what it looks like in a long axis view on the fingers with the tenosynovitis associated. Let's see, was there anything else I wanted to highlight? First treatment for this, usually corticosteroid injection into the pulley and tendon sheath. Ultrasound guided and surgical releases are also very effective, but one word of caution, I would not recommend a release, ultrasound guided or surgical, in a rock climber. Because if you do that, you're going to transfer all of the stress from this pulley here to the A2 pulley. And this is the risk in rock climbers. They already are at high risk of injuring that pulley when they go into these crimp positions where they flex their PIP joints and extend their DIP joints when they're hanging on surfaces. So that position puts the A2 pulley at risk. You don't want to release the A1 pulley. You're pretty much just guaranteeing them future pulley injuries. How do we do that ultrasound guided release? These are some just ultrasound images of the A1 pulley and the no core needle moving through it. Here's a video of that happening with volume. So first we're just numbing the area. You can use a hockey stick or any other high frequency linear probe. Here's the needle moving through the A1 pulley. In this view, we're moving from distal to proximal, but you can do this also proximally to distal. And sometimes, as in this patient, you can do both to ensure adequate release. There's some good evidence and good studies out there on these procedures showing a 95% success, or sorry, 97% success rate in a systematic review. And this is a new, or this wasn't in my last talk. It's definitely not traumatic, but can occur more commonly in people who are using their hands. So your rock climbers will present with this at an earlier age, usually in their 20s and 30s, as opposed to the rest of the population who present with it in their 40s and 50s and 60s. So it's the slow formation of fibrous nodules in the palm and eventually progressing to cords and flexion contractures of the digits. The nodules are often invisible, and physical exam is really all you need for your diagnosis. But if you're going to do any interventions, make sure that you do an ultrasound or another imaging modality like an MRI to rule out ganglion cysts, rule out tumors. You don't just want to go injecting into the hand. So your CAQ answer for how to treat this is pretty much the answer you'll get from most surgeons, which is don't do anything until there's a contracture, and then you can release it with surgery or Xiaflex. There are some, I think this is done more commonly in Europe, but people doing radiation therapy prophylactically to prevent progression. Other things on the CAQ that might cue you into this diagnosis is a family history, common in Northern European descent, like I said earlier, in rock climbers, and associated with other fascial pathologies such as Lederhosen's or Peyronie's disease. I want to call a little attention to this procedure, though. This was a procedure that was brought to me by a patient. He brought me these articles and this information on high-dose depamedrol injections into keloids and similar Dupuytren's nodules, showing that depamedrol outperforms all of the other steroids and continues to work for a longer amount of time and gets a better result if you're using this high concentration dose of 80 milligrams per cc. So I didn't see the harm in trying it. And we tried it last year. This was his nodule to begin with. A week later, 2 months later, 4 months later, 8 months later, and now he's 12 months out and he has no nodule. He has a little lightening of the skin here, probably a little fat atrophy there. And these are his Reddit posts, which are getting me way too many patients with Dupuytren's nodules flying across the country for this procedure, which I think any fellowship trained sports medicine doctor should be able to do. You can even do these, honestly, without ultrasound guidance. I would still recommend the guidance. I just wanted, this is a selfish plug. I want other people to start doing this so these patients don't have to fly so far for a procedure that's very easy to do and cheap to do. Number 17, scapholunate ligament tears. So the risk with scapholunate ligament tears, if undiagnosed, they can lead to slack wrist, which is a collapse of the scapholunate ligament, collapse of the joint, and early arthritis. So this will present as pain with chronic axial loading. So push-ups are the main thing when people will come in saying, anytime or maybe front squats, anytime they load the wrist backwards and axially, they have that dorsal wrist pain. Weightlifters. Now, you'll also see FOOSH, so the traumatic version of scapholunate tears, but we're talking about the non-traumatic ones. A positive Watson's test is your key on your exam. Your palpation should show tenderness distal and ulnar to Lister's tubercle. The X-ray can show a Terry Thomas sign, which is what we see here. Now, and this is a Terry Thomas. Now, this is should be done with a clenched fist grip, which will put more distraction on that joint. And it's diagnostic if the widening is over 3 millimeters. However, this is only going to happen if you have a full scapholunate tear. Partial tears could be missed. So if your X-ray is inconclusive, you can get an MRI with contrast, or you can get an ultrasound. MRI with contrast is above, showing that tear here. And ultrasound, we've got a normal scapholunate ligament here, and one that's partially torn with a small cyst above it on the right. How are we treating these things? Textbook should be open surgical repair. That'll be your CAQ answer. If it's a partial tear, you can try corticosteroid injections or PRP injections. This is the most common wrist ligament injury, very common source of ganglion cysts. And if that scapholunate angle is increasing over 60 degrees, there is some instability. And if untreated, it's going to continue to lead to this, which is slack wrist. And you'll see that capitate migrate proximally when that happens. Lastly, TFCC tears. Now, again, these can occur acutely and traumatically with a Fuchs injury, but they can also be chronic due to repetitive wrist ulnar deviation in our tennis players, baseball players, gymnasts. Here's the anatomy of the disc, showing the articular disc, the radiolunar ligament, there's a central portion to this disc and a peripheral. The exam, there's a lot of different exams for this, but the ones most often used are either the shear or dorsal glide test, which is shown here, where there's opposing pressure placed on the pisiform and ulnar heads, or various loading of the TFCC with extension and ulnar deviation. Arthroscopy is the gold standard for diagnosis, but 3T MRIs are comparable. Your X-ray, again, might show positive ulnar variance. And for diagnosis, ultrasound isn't recommended. I'll show you a picture of what it looked like on ultrasound if you're able to see it. Here's a tear in the TFCC that you can see under ultrasound, but I would never use ultrasound to rule out a tear. If I see one, okay, I can rule it in, but I'm not going to use it to rule out. Treatment should be with a neutral splint for 4 to 6 weeks, then physical therapy, a corticosteroid injection if needed, PRP, also would be an option, but again, I don't think that's going to be the answer on the CAQ. For central tears, debridement. For peripheral tears, repair, and if there's a positive ulnar variance, we already talked about that ulnar head resection. The other keys to note here is that the TFCC is a major stabilizer of the distal radial ulnar joint, and the piano key test can be done to evaluate for instability. These are my references. Got a lot of people that are responsible for me being where I am today. Most recently, I've added to this list the Go brothers in Green Bay, Wisconsin, who taught me the thread technique. And I don't think we're going to have any questions today, as this is a re-recording, but thank you for having me. And as always, it's a pleasure to talk about these topics.